Okay.
Hello, everyone. This is Dr. Divyam Goswami, along with my dear colleague, Dr. Bhavya Bansali, and we are very excited to have Dr. Konrad Michel, who is a clinical psychiatrist and psychotherapist from Switzerland, and he is a professor emeritus at the University of Bern. Thanks for from my memories of Switzerland. So this is it. Uh,
Oh,
this
wow.
this
Top of
is
Europe. It's very near to where I live.
Yeah, so
Yeah.
this is the passport that they give, a railway passport from Jungfrau.
Yeah. Okay.
And this is another thing which I got from Germany. So
Oh, wow.
this is a Bible, a New Testament, which I got from my trip to the nations of German people. That is the Austria, Switzerland, and Germany. I got it from Cologne, a beautiful city in eastern Germany.
Yeah. Well, good to hear. I'm impressed.
Yeah, and I hope I'll be visiting Switzerland very soon, and eager to meet you. Because this time, this is on the my wish list.
Will be a great pleasure to invite you to my place here, which is in fact like a kind of a tourist place where we live.
Yes, you told me that it is very near to Interlaken. I have been to
Yeah, that's
Interlaken.
right.
Yeah. So yes, we can begin now.
Okay, let me start right with my presentation. Where are we? Here. Okay, I hope that's okay. Yes?
Yeah, that's perfect.
Yes. So, what I'm going to talk about is a new approach to the suicidal person. Actually, it's not that new because we developed it over let me say over the last 30 years. And first of all, I want to thank the organizers, for inviting me to give this talk. And I think these DiGo Talks are a wonderful thing. And then let me start with the learning objectives. What am I going to talk about? First, I would like you to become familiar with to the person-centered model of understanding suicide. Second, I would like participants to learn about narrative interviewing. Third, I would like the participants to learn about therapeutic alliance with the suicidal person and how important it is. And fourth, to learn about ASSIP, the Attempted Suicide Short Intervention Program, as an effective brief therapy. And finally, to learn about mental pain and the suicidal mode. Now, my background, I'm a clinical psychiatrist and psychotherapist, and I've been working in the Department of Psychiatry of the University Hospital of Bern, Switzerland, for some 40 years. But what seems important to me is that I've always shared my work in the department with my private practice. So I'm very much a psychiatrist and a psychotherapist involved in treating people and teaching psychotherapy. Now, the University General Hospital in Bern, this was for us a very lucky situation because the Department of Psychiatry is situated on the campus of this university hospital. And that means that the people from the department, myself and my colleagues, were called to each patient who had attempted suicide and was admitted to the emergency department of the general hospital. And we had to evaluate the suicide risk and decide about the further treatment. So the hospital in Bern has admissions of about 300 suicide attempts every year. Now, why do we focus on attempted suicide? First of all, it's the main risk factor for suicide and attempted suicide. Second, it's important to know that after a suicide attempt, the risk is increased 40 to 100 times. And it remains high over more than 20 years after the attempt. So people who are admitted after a suicide attempt are at-risk individuals who enter the healthcare system and who can then be reached for preventive interventions. Now, what you probably learned and what I learned in my postgraduate training and my early years of internship is the medical model of suicide, that suicide basically is the consequence of a mental disorder. 90% of suicides we read in the studies fulfill the criteria of a DSM-5 psychiatric disorder, like affective disorders, psychotic disorders, substance abuse, and personality disorders. Now, the typical clinical interview with a suicidal person then would focus on symptoms of some mental disorder, usually affective disorders, depression, and the clinician then would ask the patient about sleep, concentration, or hearing voices, sort of exploring psychotic symptoms as well. Now, I was one of the mainstream psychiatrists because after my training years in the UK, I came home back to Switzerland, where actually the suicide rate at that time was 2 times the suicide rate of Great Britain. And I had learned that suicide is related to, as we said before, to mental disorders like depression. This is one of my very early studies, 1987. You see how old I am, actually. So that where I showed that depressive symptoms were more frequent in the suicide group and the serious attempters group than in the non-serious attempters groups. So really, I was promoting the model of suicide, the medical model, which understands suicide as a consequence of mental disorders. Now, 50 years later, I mean now, what do I say? I say, suicide is not an illness in the medical sense. Suicide is not a form of pathology even, and suicide is not even a mental disorder or mental health problem. So what is it then? The mental health problems are risk factors and not the cause of suicide, which is very important for me to make this distinction. To see suicide as a form of pathology is a misconception. I mean, I know that this sounds rather provocative, but throughout the years, I've come to this conclusion that really to see suicide within the frame of the medical model is a misconception. It won't get us any further in preventing suicide. So, suicide is an individual action with a personal background. Now, let's see how we developed this model. It starts with a patient who was referred to me after an inpatient treatment in psychiatric hospital due to a suicide attempt. This was a male patient, aged 35, married with 3 children. And as I say, he was referred to me for follow-up treatment after a suicide attempt with an overdose. And in the first appointment, it was very clear to me that he fulfilled all the criteria for a major depression, DSM-5. So I told him, you need to take an antidepressant. That's how the conversation happened, took place. On the left, I'm Dr. House here, and saying you're depressed, you need an antidepressant. And today, I know that he thought I'm not going to see this guy again. So he came to a second appointment and then dropped out, and I didn't hear from him anymore. And 1 year later, his wife called me and said, my husband has killed himself. Can I come and see you? So she came and told me about her husband's history, actually, life story, which in my appointment, first appointment, I hadn't actually gone into. So She showed me a letter he had written and hidden actually after the first suicide attempt. Nothing helps. I've tried everything in my life. Really, I'm looking forward to make my exit. It is important to see that my life is a succession of failures in every respect. I messed up the relationship with most of my relatives, and I am in the train of doing the same with my wife. Everything wrong. Always, always, always. My best wishes to everybody, including me. I do not know where the journey will go, but at least it does not stay in this vale of tears. Quite impressive, isn't it? Anyway, so at that time, um, in the Department of Psychiatry, in the during a coffee break, one of my dear colleagues, Ladislav Valach, told me, Konrad, you learned that suicide is related to medical or mental disorders, but suicide is a goal-directed action, not an illness. Now, I can tell you, I was not very pleased that the psychologist told me that I was wrong, that what I had learned in my training years was actually wrong. Anyway, he worked on me, and then we decided to do a case study with this patient who had been referred to me and who had committed suicide 1 year later. Now, first of all, he told me about action theory. I hadn't known about action theory, and I know that you probably don't either. Anyway, action theory integrates cognitive, emotional, and behavioral processes. Actions are part of a higher order goal-directed system, and that means actions like everyday actions, like you now joining me for this presentation. This is related to projects like work projects. I guess you may be interested in the topic of suicide because of your clinical work. But the most important thing would be what are your life career goals? What kind of person are you? What is important in your life? So this goes back also to a famous publication by Carver and Shire on the self-regulation of behavior. So the important thing here is our goals are always our goals, yes, are always future-oriented, goal-directed as part of the goal-directed systems, as we see it here. Now, the action theory for me had another very important aspect. In fact, it means we explain our actions through stories. It's very simple. Every story, every action we explain in the everyday life, we explain what we do and what we did with stories. And we call this a narrative. It's a story told to an attentive listener to explain an experience and to give meanings to events. Now, an empathic listener creates a sense of validation and trust in the storyteller. This is very important. And trust, of course, is the basis of a therapeutic alliance, which allows us to work with the patient in a constructive way. Now, this is the first publication of suicide as a goal-directed action, and you can see the case vignette is about the violin maker I mentioned. Now, looking back, I see the violin maker's story as follows, and this is part of the system we use to understand a patient's vulnerability and a patient's suicide action. Now, there was a triggering event, and I have to go a little bit back to the life story of this man. He was the son of a university professor and officer in the Swiss militia army. So he was a father who had high expectations on his son, who actually didn't fulfill these expectations. And his wife told me that her husband had always said, you know, at home, my father always told me, you're no good at anything, you won't achieve anything in your life, you are a failure. So he started to study music and then switched over to study building instruments and building violins. But he was married, had 3 children, and with his violins, he couldn't really make a living for the family. So he decided to apply to the Swiss Violin Makers Association to be certified. And he was rejected because he didn't have the kind of training they expected him to have. This meant loss of income. This meant the word failure, because this is what his father had said. And the important thing for him was that he wanted to prove to himself and to his father that he actually could achieve something, that he was not a failure. And now he was rejected. And this meant loss of a major life goal and loss of faith. So I connect this with the experience of pain and shame. And suicide then emerges as a solution to end the pain. As you read in the letter, I do not know where the journey will go. At least it will not stay in this vale of tears. Now, let's look at the letter again. Here I've highlighted the evaluation of this violin maker of his life. Nothing helps. I have tried everything. It's important to see that my life is a succession of failures, etc., etc. Everything wrong, always, always, always. But in this letter, there are also goal-directed elements, like, really, I'm looking forward to make my exit. My best wishes to everybody, including me. I do not know where the journey will go, but at least it does not stay in this vale of tears. So we concluded from this violin maker's story, and actually you can find the publication on my website, the 1997 publication, Suicide. I was convinced after that, and I went through a kind of metamorphosis from the mainstream psychiatrist to a psychiatrist looking at suicide in a totally different way. Suicide emerges as a solution to an existential threat to a person's life and identity goals. And suicide action is an inherently psychological action. So, in other words, it is not the depression that takes action against the person. It is the person who acts against oneself. Even depressed people are not driven by the depression. At the end, it's the person who actually acts. Now, looking back, that's what I felt our interview probably went like. As I told him, you're depressed, you need an antidepressant. Now, I guess he thought I'm a failure, I have no right to live. And the ideal way to communicate with a suicidal patient would be that the therapist asks the question, I would like to hear how you came to the point of harming yourself. Can you tell me? And the patient then would say, well, my father was the head of his high school. He often told me that I'm hopeless, that I'm a failure. And the therapist would then say and validate the patient's explanations. I understand. Please go on. Can you tell me more? That's the characteristics of the narrative interview. Now I'm a failure. I am ashamed of myself. I'm a burden to my family, etc. So this is how I see my interaction with this patient. Actually, a journalist from the US asked me when I told him about this case. He said, "What do you feel about this case?" And I said, I think if this man came to see me today, he would still be alive. Anyway, in the year 2000, I went to a congress of the American Association of Suicide Prevention, where I heard David Jobs presenting, and he had this wonderful model which was very close to my understanding, where he made the distinction, and this is the upper part, the traditional medical model, the therapist is higher up, ask the patient about lack of sleep, poor appetite, anhedonia, suicidality, etc. While he said, and he promoted the collaborative approach. In fact, his way to put it is so nice. I want to see it through your eyes. And so patient and therapist are sitting side by side, and they explore inner experiences like pain, stress, agitation, hopelessness, self-hate, and so on. So this resulted in a very long, over 10, 15 years long cooperation between David Jobs and myself. And at the end, in 2011, which again is a long time ago, we actually published this book, Building a Therapeutic Alliance with the Suicidal Patient. So now what is important is that in the recent years, there are some studies that actually looked into this and found that the upper one, Greg Bryan and others, that the relationship between a therapeutic alliance and that there is a relationship between the therapeutic alliance and the change in suicidal ideation. Gisin Bayar, my colleague with whom I developed ASSIP, again also published a paper, Therapeutic Alliances Related to Suicidal Ideation. And there are two other important publications, Lohani et al. Narrative Type Collaboration Effectively Reduced Suicidal Thoughts, or Hackett et al. 2022, strong alliance formed early on the therapeutic process was associated with a decrease of suicidal ideation and attempts. So it's very important to see that, first of all, the therapeutic relationship actually has an effect then on the patient's future behavior, and the therapeutic alliance is related to narrative interviewing. Now, the first conclusions are effective therapies engage patients as active participants in the therapy process, and narrative interviewing is a main ingredient of a collaborative therapy. Now, when we listen to patients, it's important also to know what patients actually tell us, because if we ask questions like we normally do in a clinical interview, we only get answers. But when we listen to patients, we hear other things. We hear, for instance, about mental pain. The pain was unbearable. My thoughts were racing. I couldn't bear this anymore. And this has, of course, been described much earlier as psych ache by Schneidman in 1993. What we also hear is, I was acting like in a trance. I felt no pain when I cut myself. I was acting like on autopilot. And this is, in fact, a sign of dissociation. And the CBT, the cognitive behavior therapists in the US, called this the suicidal mode. Now, the suicidal mode, here it is a sort of an exceptional mental situation where all of a sudden the whole experience, including cognitive, affective, physiological, and behavioral aspects, switches into this out of the ordinary mental state, which is characterized by this dissociative symptoms. Now, this year, I don't know if you ever came across Kevin Hines' story. The important thing is that these dissociative experiences are actually function like an on-off phenomenon. Once they have been established, they can again happen. And what happens here, and what actually Kevin Hines talks about, is very important to know. He says what I'm about to say is the exact same thing that 19 Golden Gate Bridge jump survivors have also said. So he jumped from the Golden Gate Bridge. He survived. The millisecond my hands left the rail, it was an instant regret. What am I doing? I didn't want to do this. And then he was falling. And we have high bridges in Bern where some people survive when they fall into the river, and they say exactly the same thing. As soon as they jumped, they knew that it was a wrong action and the wrong decision they had taken. And then he hit the water. And actually, I can recommend Kevin Hines' story. You find it on the internet. Now, this switch on and off mechanism, I had an early patient who told me I can't deeper and deeper, felt no pain. I watched the blood making nice rings in the water. And suddenly I was no more outside myself, she said. I fetched some cloth to put on the bleeding wound, and then I called my mother. So at home, there was at that time the tendency to call this what we in German we say appellative, sort of a manipulative behavior, just to get the mother to activate the mother and call the mother. But today, I know that this is not the case. It's not primarily a manipulative behavior, but it's a normal behavior that people act in this out of the ordinary mental state, and then all of a sudden they have to switch back to normal, and then she calls her mother. Now, the result of 10 years, yes, from the 1997 or 1995 to the publication of the ASSIP manual, as I say, took some 10 years. And let me shortly introduce you to this ASSIP as a treatment model. So ASSIP, it is important, is not a comprehensive model of suicide, but it's a treatment model. And the ASSIP structure, as we can see it here, the first session is completely dedicated to a narrative interview, which is video recorded. The second session, we do a video playback, and we can call it also a self-confrontation, where people find themselves in the observer's situation, watching their own narrative, which is, of course, a very different situation to the first session, where they are very often still in this suicidal mode, or create the suicidal mode again, while in the video playback, they watch themselves as outsiders. And many people look at this video and say, oh God, did I say this? I don't want to get into this state of mind anymore. I don't want to get into a suicidal state anymore. So we then hand out a text, which we call a collaborative psychoeducation, which we actually designed as a homework. People get it in the first or the second session. They fill it out at home, the questions that are included in this document, and bring it back to the next session. At the third session, then, in the third session, we do a case conceptualization, where we actually include the triggers, the drivers, the personal triggers, personal drivers of this suicidal person, and the conclusions, what they can do to actually reduce the risk. So we formulate the long-term measures like psychotherapy, if this is necessary, the warning signs, and the safety planning. And the point is that people actually learn that they can react to the suicidal development before they enter this dissociative state. So, and then this is followed by regular personal letters over 2 years. Here you see an example of my colleague and the patient. I would like to hear the story how you came to the point of harming yourself. And in fact, if anyone wants to do a video recording of a narrative interview, this is the camera we recommend, which is not expensive at all, and which actually then can be used for the video playback. The video playback here, patient and therapist watch the video, the narrative interview, and it's about the ability of the self to turn around and take itself as the object of its own view. And this is part of self-regulation. Here is an example of a letter I got after a video playback. Dear doctor, since I've seen you, I've been feeling unburdened. Although about a week ago, I experienced again something like beginning thoughts about suicide. I do feel better than 3 weeks ago after the suicide attempt. Since then, I also talked more with friends and I tried again and again to explain what happened. I feel that the interview and above all, watching together the video afterwards gave me very much in terms of working through. Today, it is much more clear to me what a silly, he says, idea such a suicide attempt or suicide itself is. Again, many thanks with best regards. So this is an example of insight that the patient achieved through the narrative interview and the following video playback. Now, the third session, in the third session, actually, we look at the handout and homework, which I described before. The printed text, this homework task, is titled "Suicide is not a rational act." Some people may say, of course, I thought about the methods I'm going to use. But the point is, we are talking about this mental, state of mind, the suicidal mode, the dissociative part where people can not or no more think clearly. So the handout text is about mental pain, about the suicidal mode, the emotional and the rational brain, actually, and the dissociative brain function, risk factors, and warning signs. So this, again, is a very collaborative cooperation where we go through the patient's answers to the homework task. So it's called a convergence of values. Of course, the patients don't have to accept everything we write there, but for instance, in the US, I saw a video where the therapist actually interviewed a big colored man, and he said, "Mental pain? No, I never had mental pain. I have back pain." But then he said, but then my girlfriend said, when we had a row, "No, go out and kill yourself if you want." And this is what hurt me so much. So you see, sometimes it's not that easy to really get into the important parts of the story. So this is the beginning of the handout homework. If anyone wants this, you'd have to send me an email, and I can send you the English version of this handout homework. Now, here is the treatment model. So if we go back to the violin maker, he had his life goals. His existential life goal was to prove himself and his father that he was useful and that he could had achieved something and that he could maintain his family. But then this also meant vulnerability, because if he doesn't achieve his goals, then this turns into a crisis. So the trigger, as I said, was that the Swiss Violin Makers Association turned him down. This created the suicidal mode, this out of the ordinary mental state, which in that treatment model, which we actually then spread. And we say, first, there's the experience of mental pain, and this is the energizer, as you can see here. This mental pain actually then leads to suicide action and planning and steps of suicide, and the suicide action execution, suicide attempt, or actually suicide. Now, the important thing is that people learn in the ASSIP treatment model that they can switch off this development at any point in this development before it is too late. Now, that there are some examples of warning signs. Allow no longer treatment to work on my trauma. I allow myself to start to like myself and to feel less guilty. That these are the long-term goals. about things that I want to do, learning to let go of what is immutable, something I can't do anything, and so on. But the important part are the warning signs: being attacked by unpleasant feelings, feeling irritation, and thoughts. That's the most important part, the cognitive aspect. I don't want this life anymore. So when people have these thoughts, they must identify them as a warning sign. Reacting with emotional, often aggressive outbursts is another part, and being agitated, feeling dizzy, not myself. And then we also formulate the personal safety strategies, like taking photos first when they're far away from the actual risk of the suicidal mode, taking photos, cutting out words from magazines. This is an example from one of the patients. Set up a playlist with cheerful music. Call Emma, call someone, the grandmother or some friends, make an appointment with my family doctor. But then in acute case of danger, they have to turn to some professional body like the GP, the ASSIP therapist, or go directly to the APSI. Here means go directly to the emergency ward of the nearest hospital. And then in session 3, we develop this formulation, the long-term measures, as we just saw it, person warning signs and so on, and we print it on a credit card-sized folded paper, which we call the Leporella. I'm not going to tell you why this name comes from, but this is something that people have to carry on them and take out in case of danger. And in fact, 2 years after the ASSIP therapy, the Swiss television came to for a recording for a documentary, and I asked the patient I had seen 3 years ago, and then he said, "Of course, I keep this Leporella, this folded paper, always with me," and this was very important for the camera, for the Swiss television team to see that these people, that it actually helps, that they keep it on themselves as a warning sign, as a way to respond to difficult and risky situations. And people in the ASSIP therapy receive letters. We try to make them differently each time, every 3 months in the first year, every 6 months in the second year. And we see this as a continuation of the therapeutic relationship and keeping the learned behavior as a long-term engram. Now, ASSIP, as you can see, has established itself as one of the most effective brief specific treatment for people who attempt suicide. And it has been translated into Finnish, into, of course, German, Korean, Iran, into Farsi, and into the Dutch language. Now let's quickly look at the study, at the RCT we did with 120 patients. So this was published in, when was it published? 2016, I think. The research article, what we found there was, with these 120 suicide attempters, 60 with ASSIP and 60 in the control group, that the number of reattempts in the 24 months follow-up was as follows. In the control group, we had 41 reattempts. In the ASSIP group, we had just 5 reattempts. First, when I saw the figures, I didn't believe it, but then it was redone and redone. And in fact, in one of the American universities, they reanalyzed the studies and they agreed that they were actually, the statistics were correct. And this means what we found were persons reattempting were 26.7%, and in ASSIP we had only 8.3%. And here you see the survival analysis. You see that the ASSIP group took much longer before people actually re-attempted compared to the control group, the red one. Now, what also is of importance is that the healthcare utilization of the ASSIP group was significantly lower. You see, the red ones is the main inpatient days, which meant emergency departments and psychiatric hospital days, so it shows that the ASSIP group had a significantly lower mean of inpatient days through the 24 months. And then Ayla Park from the London Institute of Economics did a study and actually found that and concluded that the attempted suicide short intervention program for suicide prevention is 96% more cost effective than current practice, including the training of therapists. So let's go back to the beginning where I mentioned the learning objectives. Now, I hope that you have some idea of the person-centered model of understanding suicide, what I mean by this. I hope that you learned about the importance of narrative interviewing. I hope that you have an idea of the importance of therapeutic alliance, which is connected to narrative interviewing. And I hope that you learned about ASSIP as an effective brief therapy. Of course, you won't be able to use ASSIP as such, but in fact, you can buy, if you're really interested, the manual, and there you're free to use it or actually to ask for some support from my side. And I hope that you learned also about mental pain and the suicidal mode. Now, let's put it a little bit differently. The take-home messages are: suicide is a personal action. Suicide is not caused by a mental disorder. That's my clear statement. And start, if you are faced with a suicidal patient and you start an interview, start with a narrative interview. Start the way I explained it. Can you please tell me how you came to the point of harming yourself? And then, if possible, of course, that may be difficult in your workplace, but depending on where you work, if you work in a hospital, in an outpatient clinic, for instance, you can video record the narrative interview and then use the video playback. And then try to collaboratively formulate drivers and triggers of suicidality and print it out and hand it out to the patient, and also collaboratively work out the suicide warning signs, print them, but collaborative working also working out of the safety strategies as I mentioned them and print them out. Now, let me go back quickly to narrative interviewing because I think that is so crucial. So you know by now that the sort of standard formula to open a narrative interview: can you tell me how you got to the point of harming yourself? Don't interrupt with unnecessary questions. Trust the patient's narrative competence. I have to tell you, when we started with these narratives, it was damn difficult for me to keep quiet and really believe my colleague that people have what we call a narrative competence. And just to give you one example, for instance, when I was called to a young woman at age 25 to the emergency ward who had taken an overdose, I started the narrative interviewing, and she said, I was left by my boyfriend all of a sudden when I came back to the flat where we lived together. He had taken all his belongings, disappeared, never talked to me anymore. And this has happened 3 years ago, the same thing. And the GP at that time prescribed an antidepressant for 3 months, and I was out of work for some time. But and that is part of the narrative competence. And maybe it goes back to my childhood where my parents separated and divorced when I was 7, And I always felt guilty. I always felt it was my fault. I felt that I'm not able to maintain a stable relationship. So that's what I call narrative competence, that people actually go back in their history. And then patients, as I say, have a narrative competence, try to believe in this. Why? Because this means you just want to hear. I hope that it says that the connection is not very good, but I hope that it's working. Never mind. Don't ask why, because if you ask why, you just want to hear the trigger, what triggered this, but you don't get the story. And then, if necessary, and that's important, help the patient continue the narrative by using open-ended questions. That is, questions that can't be answered with yes or no. For instance, ask the patients, if you want to hear more, can you tell me more? I'm trying to understand. Can you help me to understand? And the important thing in the narrative interviewing is that in this interviewing, the patient is the expert of his own story, while the therapist or the clinician is in the not knowing position. So the patient has to help him or her to understand how suicide developed as a goal. So if you want to know more, there is a website, ASSIP.ch. Also, I put this model of suicide into a 3-minute animated video, which you can access in YouTube or via my personal website. And there we talk about mental pain and, in fact, about the neurobiology of the suicidal mode, where the emotional brain, the amygdala, takes over and actually reduces the cortex, the function of the prefrontal cortex, where we are no more able to think clearly. So on my personal website, konradmichel.com, you find, in a nutshell, what you must know about suicide. Again, you see that in 2023, I published this book with the Columbia University Press, which includes the whole story, much, much, much more detailed, of course, than I told you. And there on my personal website, you find also helpful strategies. Know the suicide warning signs, and you can access the usual warning signs, know the safety strategies as examples, what you can do to calm down, get professional help, and what kind of safety planning you can do. So it's a long story now, and thanks for bearing with me. It's question and answer time. And again, my personal website is the konradmichel.com. Sorry, this was not the idea. ASSIP.ch, or if you have questions, email me at konrad.michel@univer at univer.ch. CH is not China, but Switzerland. So let me move out of the screen sharing. Let me see. Divyam, are you still here?
Yeah.
Oh, good.
Well, it was a wonderful presentation, Dr. Konrad, and let me congratulate you on this presentation. I think we'll be uploading this recorded session on YouTube, and it will stay forever, and it will help a lot many psychiatrists and psychologists and other healthcare workers as well.
Thanks for the feedback. Now let's see if there are questions.
Yes. So, Dr. Konrad, I read your book, and it is, again, an amazing book. And I have some questions by reading this book, that, your personal account when you were a psychiatrist in training in UK. I think that was in 1970s. And you have talked about Dr. Raj, who was a
Right.
doctor of Indian origin. And
Right.
uh,
Okay.
yes, and he has, I think he had stopped the antidepressant of a woman, and that woman went on to develop the suicidal ideation and then uh, culminated with a suicide attempt and completed suicide. And that was, I think, the first person or first patient that you lost to suicide. So tell me that is prescribing or not prescribing antidepressant, does it make any difference to the suicide?
Well, in this case, I believe it did. In fact, Raj, uh, we called him the consultant psychiatrist, had seen this patient for some time and she just didn't get better. And then he had this wrong idea of this young Swiss psychiatrist who was unexperienced, that in Switzerland there was C.G. Jung, and which was close to Austria with Sigmund Freud. So he knew about psychotherapy, and he decided to stop the antidepressants and refer these patients to me for psychotherapy. And I think this was really a wrong decision. I think psychotherapy can be done in addition to pharmacotherapeutic treatment, of course. And and then the death of this patient for me was a major blow, and it had a major impact on me. In fact, we lived out in the woods in Sussex, in the south of England, and I got afraid that her husband would come and beat me or kill me even because I felt guilty. And Raj, and this was the second point, I don't accuse him, but he was probably just as hurt as I was myself. He never actually mentioned this case anymore. He didn't do any debriefing. We didn't talk about the case. It was just silence. And that is not a good experience, and that is what should not happen with a young psychiatrist in training. So when I got back to Switzerland, I continued with the suicide research because, as I said, in Switzerland at that time, the suicide rate was twice as much as in the UK, and I felt I had to train and teach the doctors, especially the GPs, that they recognize depression and that they would treat depression.
Yeah, so I think the takeaway from this talk is also that suicide is not, I mean, you don't subscribe to the medical model of suicide, but we don't ignore the disorder as well.
It's very important. That's very important. So suicide risk factors. If there is a symptomatic, the typical symptomatic of a major depressive disorder, then it needs pharmacological treatment, of course, in addition to developing a person-centered understanding of why a patient made a suicide attempt. Right. I'm glad you mentioned this.
Yeah. Uh, I would also like to ask you about one another model of suicide. I don't know if you're aware of this. This is called the interpersonal theory of suicide. That was, I think, proposed by Dr. Thomas Joyner from United States.
That's right. Yes, that's right.
And he talks about something called the capacity for suicide. And he also describes that previous exposure to painful stimuli builds this capacity for suicide. And that is exactly what you are saying, that if the person has attempted suicide, then is more likely to attempt suicide in future.
And also what we find is with all these cases, and we have video recorded again, hundreds of narrative interviews in Bern, and we find that practically all these persons, these patients, have a background of some adverse experience, some of them traumatic, like sexual abuse, um, um, problems, serious problems in the family. Neglect is one aspect, or as I say, separation, divorce in the family, violence, and so on. And this actually, for me, is an important part of their history, to know that these early experiences actually make you vulnerable for later experiences that have some similarity to what you experienced before. In the book, I put it like this, that it has to be specific, like this patient I mentioned, that she felt that she was responsible for her parents' breakup of the relationship, and now she felt responsible for her boyfriends leaving her. And this fits together for me like key and lock. It has to be a specific interaction between the two elements. The early experiences and the later experiences that trigger suicidal behavior.
Yeah. We have one question from Dr. McAndrew from Australia. The question goes like this, and he also has a comment. As psychiatrist, it's important to not miss mental disorder. For example, depressed patient recently put on antidepressant, leading to suicidality as a part of mixed affective state in a vulnerable patient. So that is pretty much what we discussed, and he agrees with that. The question that he puts is that I agree that there is no true rational suicide, but there are well-described predicament suicide or suicide as a protest, the famous Vietnamese monk photo. Also in both our countries, voluntary euthanasia in terminal illness, where the law assumes rationality in patient. So do you have any thoughts on that?
Well, that's a good question and a good remark. Of course, my model cannot include all suicides. There are special suicides, as you mentioned, terminal illness or some cultural aspects. In my book, I mentioned, for instance, the Indian farmers that lose their crop and can't sustain their families. And this may be a reason for suicide, of course. So these are very special suicides and suicide attempts. And maybe I have to say that what we experienced here in Switzerland is the typical, let's even say average suicidal crisis of persons in the Western world, which doesn't include all the suicides. But as you mentioned, and as we said before, it's very important to see that if there is a affective disorder, let's say, or a mental health diagnosis, then this needs treatment. But we should always keep in mind that we are treating risk factors and that this is not the cause of suicide or suicidal attempt.
Yes, I would also like to throw some light on another model of suicide, that is the suicide crisis syndrome that was put forward by Dr. Gallinger from United States.
Right.
So, I don't know much about it, but I've heard that it has some 5 criterion to qualify as suicide crisis syndrome, which includes mental pain, which includes loss of cognitive control, and so on. And I also heard, I think there is an interview on YouTube by Dr. Gallinger himself who says that, if there is a person with suicide crisis syndrome, you give them a low-dose antipsychotic, benzodiazepine, and buprenorphine for emotional pain, and that should help. So what are your thoughts on that?
So Gallinger's concept is very close to my understanding of the suicidal crisis, but he focuses, of course, of the crisis itself. I'm more focused on the whole story on the development, on creating insight in the patient. But the problem is that generally suicide risk in a collaborative way with the patient to figure out what is the current situation, what are the needs a patient has to stay to remain safe. And I think Gallinger's model is very useful. And as I say, it's concentrated on the crisis element of suicide, and it helps actually to assess suicide risk. Yes, I agree with that. Thanks for the comment.
Yeah. So Dr. Bhavya Bansali has some questions. So over to Bhavya.
Yeah. So, continuing with the models of suicide, I wanted to ask that is there any analogy between conceptualizing suicide as a personal action with Dr. Martin Seligman's learned theory of helplessness, where the patient perceives that he has lost control over his actions and the actions are unrelated, the outcomes are unrelated to the actions, and so he plans to commit suicide as a last act of control. So, are there any similarities between the same? I wanted to know your thoughts regarding the same.
Thanks for this question. Yes, I know Seligman's model, of course, and I think in a way, yes, we can make a link between my model of suicide as a personal action. Um, the point is that if people don't know about the risk they have now, if they don't know uh, their dynamics of the suicidal development, then they may end up in the same situation that they're helpless, that they don't know what to do. They don't even know. I mean, I found that practically all patients don't have a concept of suicidal behavior. So they learn in ASSIP, for instance, they learn to understand what is happening. So they come out of this helplessness and gain insight into their behavior so that they can actually react, as I said, before it's getting too late, before they enter a state of the suicidal mode or the state of dissociation.
Yes. Also, I wanted to ask that visualizing the narratives of the patient by recording them and visualizing them in the next session, does it strengthen the observer's ego and thereby it mitigates the cognitive distortions that are leading the person to commit suicide?
Yes, I thanks. That's a good question and a good remark. I think that's right. That people, if they don't know about, if they have not yet developed insight that they do have a cognitive distortion, I agree with you, that they feel okay, it can happen again, and suicide is the only solution to a situation where I don't see any other solution. When I get really this feeling of being trapped. So they're of course in a way they're helpless, and this is as I say, suicide. To see suicide as the solution, maybe it's a wrong cognitive process, a cognitive element, and especially with the video playback. And most of the colleagues of my colleagues who are involved in clinical suicide prevention, they say this is probably one of the main elements in your ASSIP model, because putting the patient into the observer's seat, watching his own or his or her own suicidal story, I think this is a very important aspect. And if you talk about memory consolidation, when you look at the neurobiological or neurophysiological aspects or theories, then memory consolidation means to access some content from different angles. So the first is the narrative interview, and then, of course, the video playback is a different angle. They access the same content, and then with the homework task is another one. So people really, I think this is a way to establish a real memory, an insight, and the memory consolidation.
Yes, exactly. Dr. Conrad, I wanted to ask another question. How is the media reporting regarding this suicide there in Switzerland? Because in India, there is a habit of sensationalizing the suicide and thereby increasing the suicide rates. So, how is it different in Switzerland?
Well, it has improved now, but in the early times, in the 1990s, we did a study on the media reporting on suicide in Switzerland, and which was an interesting result because it showed that the main tabloid at that time in Switzerland, that they were really awful, that they put on the front page something like bad remarks at school, 8-year-old kills himself. And that was sort of the model presented. And then me and my colleagues, we went to see the editor of this tabloid, and we had a very tough meeting with him. I think I describe it in the book as well. And at the end, he agreed to change his way of media reporting and to avoid the sensational reporting, especially on the first page even. And what I found, and I think that's important for other countries as well, that it is very important to have a direct contact to the editors of the journals, to convince them that this is actually they're promoting a model of suicide, which we don't want to send to, this sensational reporting. So that's what I learned. It needs the personal contact to the main editor of a journal.
Well, thank you, Dr. Konrad. We are continuing now with Dr. Divyam.
Yes, so following up on Bhavya's question about the media reporting of suicide, I want to touch upon the legal aspect of suicide. Like we had this criminalization of suicide in India before 2017, and it was only in 2017 that the law actually decriminalized suicide. So what are your thoughts on that?
It's difficult for me to say, of course, because I'm not in your country and your culture. But I think to openly talk about suicide is helpful, and to avoid talking, to make it a topic that must be avoided certainly makes it worse, because people should learn about suicide, that suicide does happen. On the other hand, there's the risk that if we make reports about suicide, then it may actually be a model for people to learn that, let's say, the farmers in your country, that they solve their problem, that they make suicide. We shouldn't use the word commit, actually. That they die by suicide, and this is what is the model by Bandura, the learning from social experiences, from social constructs. So it's very much a matter of balancing the good and proper information about suicide, and on the other way, avoiding promoting suicide as an example. Someone wrote that every report that actually mentions the suicide method is an advert for this method. So methods should not be mentioned. That is one of the most important messages for suicide reporting.
Yeah. And we also have one more thing in the Indian legal system that is called the abetment to suicide, where the legal system believes that sometimes a person can incite somebody to actually die. Mm-hmm. So what are your thoughts on that? Is it true or not?
Yes, recently these cases have even emerged here in Europe, that there are some cases where in a relationship that let's say the woman there was an incentive that she was actually driven into suicide by her partner. But I think this is much more important and prevalent in your country because of the role of the woman in the family and in the marital relationship, which I don't want to go into the details. You know much better than I do.
Yeah, sure. This was again an amazing presentation, and I think that more and more people should learn about ASSIP. So is there any formal training program for ASSIP, especially for people like us in India, so all the psychiatrists, psychologists, and other healthcare workers who are seeing suicidal patients. So is there any program or formal training for ASSIP?
The point is that we are actually a small team in Switzerland, and I have retired from my work at the university hospital, and I did quite a lot of online training, like in Iran, of course. I did the online training and supervision. Um, I decided that I have to reduce my activities, but I still have, of course, my colleague who continues, Anja Giesenmeyer, with a team who continues working at the university hospital where I work together with her, where we together developed ASSIP. So if there are any requests for training, we may sort of find out between us if we can actually satisfy it. But what we prefer is a group, sort of a group of people, let's say in a mental health clinic or service, that actually wants to be trained, because this helps very much. And also training is followed by supervision, because I say ASSIP is also learning by doing. And so supervision is very important. And as I say, I can do this. This can be done online. But our resources, unfortunately, are limited. But still, we would try to see what we can do.
Yeah. So we are hopeful about it, isn't it?
Right. Good.
Yeah. There was another question that about the euthanasia. So does euthanasia lead to increase in the rates of suicide?
My answer is here in Switzerland and in Europe generally, but Switzerland particularly, the answer is no. We have in 2009, in the suicide statistics, we have separated the assisted suicide, which in Switzerland is, for instance, called EXIT. EXIT is one of the organizations that helps people who with a terminal illness, with intolerable intolerable uh, um, intolerable um, suffering from some illness, and these are the conditions that have to be fulfilled for people to go to exit. And this is totally different for me. I make a clear distinction between the usual, as I say, suicidal behavior, as I was talking about in ASSIP, and the exit, or, well, we don't call it euthanasia, we call it supported dying. Supported dying, when you have a terminal illness and intolerable pains, for instance, then you can go to exit. And in fact, in Switzerland, currently, we have about 900 cases of suicide, and the cases of assisted suicide and Sterbehilfe, which is assisted dying, have gone up to 1,500. So they're increasing all the time. So this is a new development also in Europe, in many of the countries, that people want to be able to decide about their own death. Certainly not in India, but as I say, in Europe, this is a development that has started some 10 years ago.
I think I've heard somewhere that there are cultures which promote shame, and like Japan is one. So they have high rates of suicide in Japan, and one of the factors regarded for as a risk factor for suicide is the shame that they have in their culture. So what do you say about that?
Well, I'm not familiar with the situation in Japan, but I know that young people, the suicide rates in young people is very high because of the pressure to achieve, to be successful in their training. And shame, for me, is an element in the personal aspect of suicide. That I have been working in a program, in a project related to young people, to adolescents making suicide attempts. And there, what we see is that shame is one of the main drivers. So there are certain things they did something they're ashamed of, they're not able to tell the parents. Or there are these cases of young people that claim that they go to school and they have to do sort of a diploma, write a diploma work, and they never started, and they're so ashamed they keep it as a secret and they're not able to tell the parents. So shame, especially for young people, is a very important factor in our country.
Yeah, and by the way, we also have the developer of shame containment therapy in our community. So Dr. Lisa Etherson is the developer of shame containment therapy, and she is
Okay.
very much the part of our DiGo Talks community.
Yeah, yeah. And I tell when I do presentations for the general public, I try to say that shame is a normal feeling that you don't have to be ashamed of your shame. You can accept, because everybody has something he or she is ashamed of. Yeah, but I think that would be very important part, actually, the psychoeducation about shame. I agree with you.
Yes. The next question would be that, as Dr. Gallinger is proposing a diagnosis of suicide crisis syndrome to be included in DSM or whatever further editions of DSM we would have. So are you proposing anything like that?
No, because what we are doing is not focusing on actual suicide risk. I mean, what I promote is if it's about suicide risk, that it has to be collaboratively done with the patient, and it's not the doctor or the clinician who can decide on a person's suicide risk on his or her own. It's impossible. We only can do it in a collaborative way, and that collaborative way would also be starting with a narrative interview. And I mentioned this, I think, in the book, that a narrative interview doesn't have to last 1 hour. It can be done in 20 minutes,
Yeah.
because people are able to talk about their background, about how they came to the point of harming themselves. And then from there, you can actually develop the measures and the needs. What are we going to do about this next time? Is it necessary to be admitted to a psychiatric hospital? Can we do a follow-up treatment? Can we do a follow-up appointment the next day? Something like this. And Gallinger, with his concept, of course, I think he tries to get out of this difficult situation that generally we know that risk assessment doesn't work. It's not possible. But I think with his way, with this concept of the acute suicidal crisis, that could be a way out, and it might be helpful to include that in the DSM. Yes. I'm very impressed by his work, but as I say, this is a bit different because he really focuses on the suicidal crisis syndrome.
Yeah, and I think the suicidal crisis syndrome that he talks about is about the imminent suicide risk. And then we have the long-term suicide risk as well, which is different from the imminent suicide risk.
Yeah, I make this distinction as well, because long-term suicide risk I talked about is, for instance, people who have made a suicide attempt or several suicide attempts, who have risk factors, medical risk factors like diagnosis and so on. This is the long-term risk where we know they have an increased risk. What I described recently in an article, and what I found helpful, that in the VA, in the Veteran Administration in the US, they in their patient records they put a red flag, what they call, and this means increased suicide risk. So each time the patient comes to an appointment, address suicide risk, and this makes sense for me.
Yeah.
But yes, I make this distinction between the actual suicide crisis, the suicidal crisis, the acute crisis, and the long-term risk.
Yeah. So this leads to another question in my mind, that if you have a patient who doesn't have the history of an attempted suicide, but presents to you just with the suicidal ideation for the first time in his life, in his or her life, then would ASSIP work for that person?
Well, we couldn't do ASSIP because ASSIP, in a way, requires that the patient has actually acted on the suicidal thoughts. But of course, we can do a narrative interview. Again, we can open the question, can you tell me about how you came to the point that you think suicide might be a solution? I've just, last week, I had a 14-year-old who actually had very clear suicidal thoughts and plans. And it was very difficult to actually convince him that he should go to a psychiatric hospital because the risk was too high.
Yeah. In your book, you also talk about the difference in the suicide rates between Switzerland and UK. So, if you were to summarize all the years of experience that you have now, what can you say? What was contributing to that difference between the suicide rates in Switzerland and UK?
Difficult to say. In Switzerland, we used to say that people kill themselves and we don't talk about it, especially in the rural areas. But I have to say that the suicide rate in Switzerland has really come down. It was something like 24 per 100,000 inhabitants per year, and now it's down to 10, which is very close to the UK figure, which I think is about 8 or 7 per 100,000. So, and it has come down in most European countries. It's difficult to say. We don't know why exactly, but I think knowing and about suicide, and of course also depression, treating depression, that you need to contact someone. You can go to your GP, and knowing about depression, especially for men, can also be helpful, because then talking about depression can also reduce the suicide risk.
Yeah, and I think certainly ASSIP also has a role in it.
Right, certainly, yes, because in Finland is the country that is the model of how they spread ASSIP all over the country, right up to Lapland. And they told me after 10 years ASSIP in Finland, they said, you know, Konrad, you don't know how much your concept changed the whole attitude towards suicide in our country. So I think ASSIP is not only just for those people that undergo the treatment, but it can actually have an effect on therapists, on clinicians, to have a different view and a different understanding of the suicidal person.
Yeah. So you are doing a great job, Dr. Konrad, and you are helping a lot of people. A lot of physicians treat their patients. So thank you very much for this wonderful talk, and thank you very much for this work that you have done in the field of suicidology.
And of course, thank you both again for inviting me, because I think these talks that you're doing, the DiGo Talks, are just a wonderful thing. Thanks again. Okay.
Yeah. Thank you. See you
So
again.
do we conclude the session here?
Yeah. Yeah. We conclude the session.
Thank you.
Okay.
Bye.
Thank you again.